Welcome to our 7th webinar in the series on ethics and COVID. My name is Adnan Hyder. I'm the Senior Associate Dean for Research and Professor of Global Health here at the Milken Institute School of Public Health at George Washington University. It's my great pleasure to be moderating these webinars. May I please request my colleagues that there are a couple of individuals here who require, I believe, special assistance. I believe the captioner was part of that. Could I request Lauren and Michelle to please look at that? I want to make sure that everybody can attend the webinar. And in some cases, if people can actually not hear, yes, I'm getting the message on the chat board. We will try and get the captioner back on. Please, could you send a message to them to identify themselves? We want to be very careful. Ladies and gentlemen, our webinar today is on a very important topic. It's looking at the ethics and COVID-19 from the perspective of disparities. We will focus the discussion on racial and ethnic disparities, but our colleagues will be also bringing in other perspectives as well. I want to make sure that I welcome our two fantastic speakers for today, but also welcome to all of you. And I know many of you have joined from all over the world. Once again, two logistic announcements. The first one is, yes, I'm getting the messages about the captioner. Could you please request them to come back into the room? And I'm requesting my colleagues, Hina and Lauren, to ensure that that facility can be provided on. I'm trying to get that message. Thank you so much. But the second one, and the reason we have to be very careful, is that we've had a Zoom bombing incident. And so we are now extremely careful about anybody entering our room. And as you all know, it requires a password, and it also, we will be closing the session. We will be closing the session just 10 or 12 minutes afterwards. So if you have a known colleague, a known friend, please text or email them right now to come in, because we will be closing the conference. This includes any assistance that you have. Please ask them to rejoin and put them back in the waiting room. Now, ladies and gentlemen, we have to, and yes, for those of you who have asked the question, we will be recording these webinars. They're available on our website. My colleagues will be putting on that website on in the beginning, and also we will be going ahead and putting the website where we will locate these webinars at the end of the webinar as well. I apologize again for the slight few minutes of delay here, but I'm very excited that as we discuss the ethical issues that this pandemic of COVID-19 has created, we do not forget the other pandemics that affect our country in particular, but also our global community. And that pandemic of injustice, inequity, and unfair treatment of individuals and people, sometimes determined by their gender, by their ethnicity, and by their race, has come to the force now in the case of this pandemic as well. And by its very epidemiology, by who it affects, by who controls the power and who controls its treatment, we've come to recognize that has to be recognized. And so I'm so happy that Professor Rokhaya Yarbi has joined us from St. Louis University. She's a professor of law. She's a member of the Center for Health Law Studies at that university, and executive director for the Institute for Healing Justice and Equity. How appropriate is that given our current circumstances? I am particularly excited because through these webinars, I get to meet fantastic colleagues like Professor Yarbi, and I'm very excited today that she will lead us with some opening comments and reflections on this topic. So over to you, Professor Yarbi.
Great, thank you. So I want to share the slides. Thank you. So thank you for having me on this panel, on this webinar. And I'm going to begin by discussing disparities. So when we look, next slide, when we look at this pandemic, people often say that this is new, that the disparities, particularly for racial and ethnic groups, are new, and they are not. So this slide just talks about how it has impacted American Indians all the way back to the 1918 flu, where we see higher rates of disparities in terms of infections and deaths. Next slide. And even in 2008, Blumenschein had hypothesized that racial and ethnic disparities in infections were actually caused by structural issues, particularly disparities in exposure, disparities in susceptibility, and disparities in treatment for the virus. Research in 2009 tracking the H1N1 pandemic actually supported this hypothesis to show that there were structural issues that led to disparities. Next slide. And so today I'm just going to talk a bit about structural discrimination and how it is one of the main reasons for disparities in racial and ethnic infections across the world. I'm going to use the lens of the United States, talk about the ways that it shows up, and provide some solutions. Next slide. So when we talk about structural discrimination, there are many things that fall under structural discrimination. I'm going to talk about the ways that our systems, healthcare, employment, housing, and emergency preparedness are structured to advantage the dominant groups and disadvantage minorities. And it's not just the actions of the systems, but also organizations that address this issue. Unlike most discrimination claims, particularly in the US, it does not require intent. It can be neutral policies, but the ways that they are implemented impact racial and ethnic minorities and other minority groups. So turning to the next slide, social discrimination and COVID-19 disparities. I'm going to give you some examples, particularly of the US response, focusing on essential workers and access to healthcare to show how this has actually connected and influenced disparities in infections and disease. Next slide. So when we think about the US COVID-19 response, one of the major ways that we can see structural discrimination is in the allocation of resources. Here in the US, we have focused primarily on questions of ethics surrounding access to healthcare, masks, personnel, and funding, but really only focused it on hospital care. Why is this a problem? Because many of racial and ethnic minorities don't have access to hospital care. For example, when I look at my city, St. Louis City, the zip code with the highest rate of infections and deaths, predominantly African American, and lacks a public testing site and a public hospital. So when we're thinking about wrestling with issues around allocation of resources, ventilators, that really doesn't get to the needs of those who are most impacted. The same thing with farm workers who don't have necessarily access to hospitals. Looking at some of the other issues, particularly in the US, is the blaming of minority victims. Initially, there was a discussion about how we want to support it, how we want to stop it, but lots of different ways that we have talked about it now that it is impacting racial and ethnic minorities, which is preventing us from actually supporting and helping those most impacted. I just listed a few, but what it does is it shifts the focus on support and protection of racial and ethnic minorities, Latinos, African Americans, low-wage essential workers, from support to blaming them for actually doing this. Next slide. When we think about essential workers who are asked to continue to go to work and risk their lives during this time, particularly in the US, we see that a majority of them are people of color, are women, and are in poverty. They have been impacted, but not necessarily supported. And so when you look at agricultural workers, not being tested and not even necessarily knowing that there have been people who have tested positive. Next slide. And so how is this an example of structural discrimination where policies advantage the majority or corporations and disadvantage racial and ethnic minorities? One example is when we look at the economic protections. Direct care workers who are home health aides, they work in nursing homes, they work in homes, provide an essential benefit for us, particularly during the COVID-19 crisis. But they live in poverty. They rely on food stamps and Medicaid. They do not have paid sick leave. And so they must continue to go to work and work in close quarters without protective gear. They're also not covered by some of the COVID-19 Relief Act that was passed in the US. So if they don't go to work, basically they don't get paid. When we look at agricultural workers who have incomes below the poverty line, and again, predominantly people of color, sometimes a majority, particularly in the US, immigrants, that we see again that they're not covered by the COVID relief, and so they have to continue to work. In addition, the federal government was actually seeking to lower their wages during this time. So imagine you're already making below the poverty line and the government is trying to negotiate to further lower your wages. And so again, this is an example of racial and ethnic minorities being harmed by policies that are supposed to support those continuing to work, and instead the money actually going to corporations or to others who are able to stay at home. Next slide. This is further borne out, particularly in the US, when we look at safety protections. So here in the US, not too many national actions to address the stop of COVID-19. One of the executive orders that the president signed delegated authority to the USDA agency to regulate to ensure that meat and poultry processing facilities stayed open. The other executive order that he signed was for masks. But specifically in the executive order for masks, it noted that the mask should stay within the US, right? That he was doing that to ensure for the protection of US citizens. With the executive order regarding meat, that was not the case. And so what happened? The order was signed and companies continued to export meat outside of the United States, even though their main reason for continuing to keep open meat processing plants that were hotspots for people dying and being infected was that there was going to be a meat shortage in the US. But they continue to export meat outside the US. Furthermore, we see that some of the agencies that are supposed to protect the safety and well-being of these workers are actually allowing speed waivers that require workers to work more closely together. OSHA, which is supposed to review and inspect complaints about health and safety violations, has said we're just going to allow meat processing facilities to make a good faith effort. And so what happens is that these essential workers, which are predominantly poor people, people of color, immigrants, are left without protections and are harmed. Next slide. The final issue that we see is access to healthcare. And here I'm speaking expansively, not just about the essential workers, but about racial and ethnic minorities and low-income people who are not able to access care. Many of the testing and treatment sites for COVID, particularly in the US, are located in middle-class and affluent areas. I noted that before, but I do want to highlight some other key factors that immigrants, even if they are documented, often tend not to go to these healthcare centers because of the increased policing that has happened. And you see that even when sometimes states try to set up testing facilities in collaboration with groups, that you still have people being biased against Latinos. And that you see is the last example on the slide, talking about a nurse who was asking for additional ID and actually called the police saying that they were undocumented immigrants while they were trying to get testing. The other examples are African Americans who were turned away from care, including one, a nurse who was a healthcare worker in Detroit and presented at a hospital where she actually worked and was turned away 3 times for receiving care. So why do I highlight this? Next slide. I highlight this to push us to think differently about how COVID-19 has been discussed. I think here in the US, predominantly, we treat COVID-19 as something new. It's really not. It's just a continuation of our ineffective response to the 2009 H1N1 and Ebola and other pandemics that have predominantly hurt and harmed low-income individuals as well as racial and ethnic minorities. There were articles back in 2010 that talked about the stigma that was placed on Latinos in particular for H1N1, blaming not only them for bringing it in the US, but for the problems that they had. And we see this continuing today, even with some of the people who have been charged to help them. We need to focus on not just allocation of ventilators and hospital care, because that's really not that's the last step. We need to think about testing, supporting people who are essential workers, to people who cannot socially distance because they don't have a car, they have to be on transportation, they're living in houses that don't have clean water, whether that's in rural areas or urban areas. And so some of what we need to do is to actually support policies and actions that address structural barriers like paid sick leave, hazard pay. These are some of the things that we need to do. And I would just say one last thing for solutions for ethicists is that we need to focus on the structural barriers and not necessarily just on genetic links. I'll stop there with that in terms of solutions for ethics. But next slide, here are just some examples of some policy solutions, because I think it's so important for ethicists to talk about what are the policy solutions for addressing this in terms of basic income for essential workers. And then finally, I just want to show, next slide, if you're interested in this, here are some readings, articles that I have written about this, and I'll stop. Thank you.
Thank you very much, Professor Yarby. This is so important. First of all, thank you for reminding us that this is not something we discovered as a result of COVID-19, but has existed for centuries, especially in our country, which is incredibly important. I really like your framing of stop blaming the minority. I think that's a very important message, loud and clear from your presentation. And the fact that you've highlighted the plight of workers in agriculture, in meat industry and other places is incredibly important. And I hope we get the time to come back to them. Thank you for your opening comments. I'm now very excited to introduce our next panelist, Professor James Lavery. For those of you who know, Professor Lavery is the Conrad Hilton Chair in Global Health Ethics at Emory University and Emory Rollins School of Public Health. He's also a professor, like myself, in the Department of Global Health. He's faculty at the Center of Ethics at Emory, and of course comes from many years of service in Canada at the University of Toronto and other places. I'm personally very happy to see Jim finally. He's a great friend, but also a very busy and important person, so it's tough to catch him sometimes. But thank you, Jim, for being with us, and over to you for some opening reflections.
Well, Adnan, thank you so much for the invitation. We met in Bangkok in 2000, and then a few months later we met Paul when he was a Fogarty Fellow in Baltimore. So it's a real pleasure to be here. And let me just reiterate your point about Professor Yarby's presentation. I think it just set things up really, really nicely. So I'm going to just launch in. I'm not going to use slides, in part because I think this is it's a very tricky area. And to be just completely frank, I'm not an expert in these areas. And I was excited about this invitation, but I want to try to be careful to not try to overreach in terms of my understanding of this area. But what I really wanted to do was try to provide a few thoughts about what I see as kind of framing of the ethical discussion. And again, Professor Yarby has set this up really beautifully, I think. I think we tend to fall into quite simplistic ways of discussing ethics of race and racial disparities. And in particular, I think we tend not to discuss the ethical dimensions of the pathways that give rise to disparities, exactly as Professor Yarby has set up so nicely. And so what I'd like to do in the next few minutes is just to flag a few points that I think are both particularly important and also particularly challenging for robust ethical discourse about racial discrimination. And Adnan, like you, I think given the recent experiences, again, here in the United States, I think that I'm tending to focus my attentions here in the South, in Atlanta, from what we're seeing going on around us right now. I wanted to start with just a minute or two about the concept of race itself. And I came across this really interesting quote the other day by a guy named Anthony Peterson. And the quote is as follows. He says, "We tell our children that race is real, but it doesn't matter, when the opposite is true. Race isn't real, but it matters very much." And I think we tend to, at quite a fundamental level, I think we have permitted, I think, a kind of false narrative about biology to shape the way that society is structured. So, phenotypic expression that is almost entirely unimportant biologically forms the basis of blanket assumptions, I think, about all people who share a particular pattern of expression of, a protein like melanin, for example. But because that phenotypic expression results in visible differences, it has served, I think, very well as a handy kind of sorting criterion as a way to emphasize otherliness that serves a bunch of different purposes. So in this country, the history of slavery, of course, is the backdrop to all of these conversations. And I think one of the really fundamental things that slavery delivered as a backdrop was it gave a means of translating this biological phenotypic notion of other into a narrative of inferior. And so, in 1851, Samuel Cartwright, who was a US physician, argued that slavery was the natural state of African Americans because they benefited from the hard work and were, in his view, incapable of looking after themselves outside the system. People who had literally been shackled in the bowels of ships and survived those kind of journeys were incapable of looking after themselves. And really importantly, invented these two psychiatric disorders, one called drapetomania and the other one dysesthesia ethiopica, to frame the tendencies of enslaved people to run away from their enslavers or to resist hard work, to frame them in terms of a mental illness. So these other ways then of differentiating, not just on phenotype, but in these heavily value-laden ideas about inferiority. So these early kind of medical views, I think, shaped not only the relationship of African Americans with society more broadly, but also I think really started to lay out some of those pathways that Professor Yarby alluded to in terms of the relationship to the healthcare system that, as we know and as we're seeing, persist very much to this day. And there are all kinds of really excellent books about this. I just happen to have Medical Apartheid by Harriet Washington on my desk for something else today, but that's about history, more about medical experimentation. But there are just all kinds of really excellent books to dig in more deeply on this. And just recently in the New York Times this past Sunday, there is about what Wilkerson had a piece on, America's enduring racial caste system. And so one of the other ideas that I want to put out then is that this notion of caste, I think, is kind of interesting. And I mean, some people are critiquing the piece already, but the idea of caste has something to do with kind of layers or strata within a society. And I want to just kind of plant that idea because I'll come back to it in a second. The second idea that I want to just put out for thought is this notion of agency. So racism is actually a difficult concept. It's a tricky concept. In normal use, racism, I think, is tightly associated with discriminatory actions and attitudes of individuals. That's how I think we were brought up to think about racism. You know, we would say, he's a racist or she's a racist. It's a kind of notion of individual agency. And so, of course, some actions and some attitudes are plainly racist, are motivated in those ways, and we can see them. But some actions are ambiguous, and some attitudes, in fact, are kind of impossible to determine. And I thought Professor Yarby's point about the fact that findings of racism in the law don't require intent, at least in some circumstances, is really important, I think, to emphasize the point that sometimes we just can't access the individual agency thing that we need to make determinations of racism. And so treating racism kind of only as a matter of personal agency, I think, is quite limited as a way to structure a robust ethical discussion. And again, Professor Yarby has set that transition up really, really nicely. So structural racism, I think, is how we look beyond individual agency to see features of a society that endorse or facilitate or even openly support discrimination based on race. And so structural racism is a way of incorporating and enacting racist attitudes and actions into the workings of society. And how do we do that? Well, we do it through laws, we do it through policies, we do it through practices and social conventions, all kinds of instruments of incorporation, if you like, of these attitudes and practices into society. So one of my favorite books on this topic, and Professor Yarby, I haven't read yours yet, but I will go and read yours. But one of my favorite books is from a colleague here at Emory University, Carol Anderson. And she wrote a I think, an important book called White Rage. And she does a review of history since Reconstruction after the Civil War, and highlights just a myriad of incredible and very troubling examples about how legislative strategies in particular were used to suppress votes, to deny education, to do just all kinds of things. But it's those legislative, those structural elements, I think, that are really critical. So this notion of structural racism then is kind of insidious. I think about it as a way of baking racism into a society. It's also a kind of division of labor, if you like. So if a country or a state's laws are discriminatory, then individuals who hold racist attitudes actually have less work to do, to perpetuate racist attitudes and actions. So in other words, these structural features facilitate racism. Back to the etymology of that word, they make easier the actions of racism. It alleviates work from people to make sure that these racist attitudes survive. And it also makes racism less visible for those who wish to perpetuate racist attitudes, even if the experiences of those being discriminated against remain potent and concrete in every way and in every day. So this is very interesting kind of distorted reality it sets up. So I just have a couple more minutes on this idea about disparities as they're being manifest in COVID. I think, again, I just keep coming back to the way Professor Yarby set this up, but what do those disparities represent? I think that's really where the important ethics lie. And I want you to think again about this idea about layers or strata or castes in society. When we're talking about epidemiology, we're always talking about stratification. Epidemiologists love stratification, but think about strata not so much in epidemiological terms, but in those layers that I just described. So, there's also a long history in modern epidemiology. Michael Marvin and a lot of UK epidemiologists who've looked at economic, social status, and class as some of these kind of different strata, but also as reliable predictors of a wide range of health outcomes. And so one of the points that I'd like to just plant for discussion in ethical terms is I wonder whether these strata are really just different ways of categorizing various levels of constraint on human flourishing. You know, slavery might sit at the absolute extreme of that continuum of constraints on flourishing, and perhaps inheriting a family fortune with no requirements to pay estate taxes might sit at the other extreme of constraints on human flourishing. So these categories don't determine outcomes, as we know from incredible success of people who have come from those terrible places of hardship, and also terrible failures of people who have come from those incredible places of privilege. But they very powerfully shape the different channels through which people can pursue their life goals. So in ethical terms, one of the concepts that we draw on a lot is this idea of fair equality of opportunity. And so I just want to kind of plant that notion of equality of opportunity really in what we're talking about can have something to do with these constraints on human flourishing. So as we turn to discuss COVID-19 related disparities, then I want you to just think about the extent to which these pathways to various epidemiological strata have been paved by these various forms of structural racism, and then the almost infinite number of ways that the structural racism has diminished fair equality of opportunity for human flourishing. And we don't factor these effectively yet into our analyses. And the final point I'd like to leave with is this idea of essentially it's the counterpoint to agency, and it's about tolerance and this idea of intergenerational obligations. So the ethics of structural racism, I think, leads us to very complex questions. One of them is, what obligations do Americans, say, and others, and I'm an other, I'm an alien, I'm a Canadian, just waiting for my green card. But what obligations do Americans have to oppose and work to end structural racism? So one of the things you hear a lot is, well, you know, I had no idea that that law was in place, or I had no idea that was going on, and I haven't seen any racism. I just heard this morning on the news, Peter Navarro saying, oh, we don't really have racism in California. And so is that kind of response a sufficient answer ethically? And then the second part is the lack of explicit opposition to racism and to structural racism, and let's call that tolerance for the sake of argument. Is it actually just a form of complicity? Is it just a kind of passive form of complicity in the structural racism that we've experienced? And so this, of course, the framing for this currently is around reparations. And then, so the final points that I'd like to leave with then is, does tolerance give us any more traction ethically in addressing questions of intergenerational obligations? Or, as people say, you know, I didn't own slaves, but we all have tolerated structural racism in various ways. And then finally, to just reiterate that health disparities like COVID are simply the most recent indicators of structural racism and tolerance, and so might offer, again, an important opportunity to reframe how we study and interpret data on racial disparities. So I'll end there, and hope that was a useful set of thoughts.
Thank you.
And again, really appreciate Professor Yarby's setup for that.
Well, thank you very much, Jim. That was great, and a great follow-on from Professor Yarby's. I think starting from your raising the question of what is race and the biological determinants to, I love this concept of moving from who is the other and who is the inferior. And then thank you for raising questions on agency and structural racism, but very important, your ending of obligation. On Twitter, we have hashtag silence is not an option, right? So silence is complicity. And to quote Kendi's work, you have to be an anti-racist, not just speaking in silence. So these are all important issues that we are grappling with today. So ladies and gentlemen, again, I have been keeping a little bit of an eye on the chat board. We have a number of questions coming from different parts of the world first, and I'll address some of the logistic issues later. But I want to get maybe back to you, Rukaya, if I may, because you talked a little bit about what are the solutions to this, and some of the questions on the board are really asking about how do you dismantle racist policies? How do you go about debunking some of these ideas. Would you like to reflect a little bit more on that for a minute or two?
Sure. I think that the process is beginning to some extent here in the US, where lots of communities who before would never have said that racism is a public health crisis are now beginning to acknowledge it. I think, though, oftentimes when they acknowledge it, it's not in changing the structures. And so you'll see some communities actually say, we're going to change how we do things. We are going to put money to communities. I would say particularly when you look at COVID, one of the examples that I've seen that I think is important is in North Carolina, who has recognized that Latinos are being disproportionately impacted. And so giving money and partnerships to the groups who work with Latinos to be able to provide testing, to provide support, to me, that is key. Because what structural discrimination, racism really is, for me, is about power and controlling and limiting individuals and communities' ability to take care of themselves. And so to me, that's a move towards saying, we know you understand your community, we're giving you the power to do it, and we support you. And I would say one last thing, because I saw in the chat, how do you support underserved communities, whether it be racial and ethnic, low income, is going to them and giving them the power and the money and the support that they need. They can't necessarily do everything, but as you noted in the slide, at the very least, you need to give them the information. The fact that the CDC will not give information to Native American tribes about the infections, the fact that states were trying to shut down their ability to close off their tribal communities to protect themselves, that to me is an example of structural discrimination. And how do you change that? By giving power back to people to be able to address the needs that they have, supporting them financially and materially, and continuing to do that.
No, that's great. Thank you so much. Jim, just to build on what Rokhaya said, what about within the academy, within higher education, within research circles? How do we begin to address this notion, both from a research but also an academic perspective? Would you reflect on that a little bit?
Sure, yeah, and I'd be really pleased to try to build on it. And I think, you know, the thought that was formulating in my mind, I think does map onto your question, Adnan. And it's really about the power of narrative. You know, parents all want their kids to be doctors, you know, and we want to have like influence, or lawyers, and lawyers have more influence in legislative terms. But we see, especially in the last few years, the power of framing and narrative around issues. One of the things that, as an outsider, as a Canadian coming into this country, and this is the second time I've lived in the US, and I'm here, I'm not here under duress, but the narrative in this country about taxation is actually mind-boggling for people coming from other countries. My effective tax rate is, when all things are taken into consideration, is about 27%. And my students are in terrible debt. And I just think this is absolutely crazy that taxation is so low. And of course, the narrative is that taxation is evil and should be reduced at all costs. And notions of progressive taxation, I think, are difficult for people to grasp. So, Adnan, in the academy, I think, you know, without becoming political instruments, I think that we can do a better job of teasing out some of these underlying structural features that we're talking about, including the potentially most powerful instruments like taxation, like better protection for voting, and try to situate them in an ethical discourse in ways that I think we tend not to do. We tend to see them as politics and not as interfacing with these kind of deeper ethical challenges that we're all trying to grapple with.
No, thanks very much, Jim. That's very appropriate. And Rukaya, I mean, some of our participants are really interested in going beyond just, for example, the racial part, but also thinking about insurance. Lack of insurance has a huge vulnerability, and that has manifested in COVID-19. But also distribution of food stores, distribution of grocery stores pertaining to healthy diets. So could you talk a little bit about the expanded view of vulnerability here?
Right, so I just focused on employment, but there are a whole host of issues, right? So when you look at housing, particularly the fact that in lots of low income communities, they don't have access to clean water. That's the same thing in rural communities. They don't necessarily have access to food. And I saw in the comments, somebody was talking about Detroit, where I'm from, and the lack of access to healthy foods or to Walmart. I think that's important. And initially, when you looked at a lot of discussion about the disproportionate impact on Native American communities, the question was, why were they leaving their communities? Because they didn't have access to grocery stores and the things that they needed to be able to socially distance. And so I think it's important when we look and going back to this discussion about structural discrimination and racism, that we often think about it as an individual perpetrator. We think about that under the law, and it's not, it's structural. And let's be clear, I think a lot of people in the US look at it in terms of slavery. And I think a lot of people outside of the US look at it particularly in terms of colonialism, but we have a history, a long history of separating people and keeping people as a second-class citizens, as workers. And the narrative continues to do that. And so it's hard just to say, right, that it's not because there's social distancing. It's all the things that facilitates people not being able to wash their hands or to social distancing. It's access to healthy foods. It's health insurance and being able to go to the hospital. I saw the comments in the chat sort of saying, well, it could be particularly in the US because you only get care based on your ability to pay outside of the emergency room, right? But that here was supposed to be addressed by the CARES Act, right? The Relief Act that said people don't have to pay for testing. What they left out though, and this is again why it's structural discrimination, we'll pay for the testing, we're not gonna pay for the care. The test, I'm sure, only costs maybe $100. The care can run anywhere up to $50,000 to $100,000. And so that's another structural barrier for racial and ethnic minorities, low income, as well as women, trans people, a lot of people who are in vulnerable or marginalized communities.
Yeah. No, thank you. I think that's exactly spot on. I think your examples are exactly where we see these impacts. Jim, first of all, greetings from Professor Bavon Mupenda from Democratic Republic of Congo. He's online.
But I just responded. Yeah, great to see. What a great, I mean, what a great audience. I've got so many friends
Jim,
in there. It's brilliant.
He's really asked a very important question that in other cultures, and that's why we have a global perspective. In fact, COVID-19 is being seen as a disease of the rich because the people who are online and the people on Twitter and the people on the social media tend to be from a particular class, and the quote unquote, the common man isn't connecting. What do you think are the implications of that, particularly in terms of obviously resource allocation, impressions, and justice issues?
Well, I mean, it's really fascinating. I mean, I was thinking about, you know, Babin in Kinshasa, and, you know, just a couple of weeks ago, the statue of King Leopold was torn down in Belgium, and that seemed to last a hell of a long time, that statue. So, and again, people don't understand some of the history. But I was actually had a call with a colleague in Brazzaville in Congo, across the river from Babin last week, and talking about the relatively low number of cases in Brazzaville, because of this kind of insulation effect that you see because of relative isolation, particularly from air travel. So we know that air travel is the prime route, at least of initial distributions, not necessarily transmission, but initial distributions around the world. And so there is this kind of interesting insulating effect that you have when you're not as well connected as we are here in Atlanta, the world's busiest airport. And so I think there it's quite easy to see how people can view people who have more resources. They're the ones that are on planes. They're the ones that are traveling. They're the ones that are kind of still moving around, have this kind of, we talk about upward mobility. In this case, it's literal mobility as means to kind of bring and take away the virus. So, that's just kind of one piece of it for sure. And then I think, if I may, it also touches on another feature, I think, of structural things we're talking about at a global level. And I don't want to underplay those. And one of the things that you see, say, in health systems is the incredible incursion of private sector, private equity financing of health systems. And really, if we look back and ask why we're experiencing so many of these issues here in the United States, part of it has to do with we have a $3 trillion a year healthcare industry in the United States. And why Bernie Sanders couldn't get his agenda delivered, I think, is because you can't account for the 20% or 18% profit that has to come out of $3 trillion a year in an industry. Where does it go? So I think that one of my worries about global health systems and national systems in a global sense is this kind of incursion of private ownership and, like I said, private equity investment more and more driving agendas as well.
I think that's a great point, Jim, and thanks for responding, because I think that there are two viewpoints. One is viewing and calling for further private sector engagement in health, and the other is extremely cautious about what people like me call commercial determinants of health. That is the avenues and the forces that drive us to, as a population, do things that are harmful to our health eventually, right? So these are the alcohol, the guns, the sugar-sweetened beverages, and so on. But
yeah, Adnan, if I can just say one quick comment on that. So my cousin in the UK is a senior, well, he's retired now, but he was a senior executive in one of the world's largest companies. And his argument was always that there are some capacities that private sector organizations have, manufacturing, supply chain, that are unrivaled, that you cannot match in public sector. But he said the part that people get wrong is that the private companies can also be some of the most corrupting forces ever imagined in the world. That's an insider from one of the world's largest companies. I think we don't acknowledge that enough.
Sure. But I'd like to pivot in the last few minutes to several of the comments that have talked about the power of data and the power of information. And it took the first few weeks of the pandemic, even in this country, to call for agencies to disaggregate their COVID numbers by race and ethnicity and age and gender, because the original data was not like that. And now, of course, states are providing, so for example, I live in the state of Maryland, where nearly over 50% of the cases have been in minority populations, right? And so this has been important for us. So Ruqayyah, what is your perception of the power of data? What advice can we give to our researchers going forward, as several of the commentators would like us to talk about?
So for me, and this goes back to Dr. Camara Jones and others in my work, I think we definitely need to have data. We need to have data disaggregated, and we need to have data that supports the structural barriers. My worry, though, when we just disaggregate by race and don't put it into context, then that leads to the discussion of blaming of genetics. And so I've often argued that if we're going, I argue that we shouldn't necessarily collect data based on race, but data based on racism, socioeconomic class, where you are, because that is more telling than just about race. It really is issues about discrimination, racism, classism, discrimination against those who are disabled. And so when we start to do our studies, what we need to start to disaggregate our data by are by factors that we can actually address. You can't change a person's race, but you can change structural issues that go with racism and poverty. And so I think that it's important that if we say, and I try to do it here, that if we say that there are racial and ethnic disparities, it's not because of some biological factor, but it's because of structural barriers. And so if we're going to do research about particular things, that we need to include those as variables, not just race. Because what we will do is just use race as a proxy for things that we never get to. And so if you're going to do studies, have structural barriers, have housing, have employment, have education in there. Look at where people live, look at poverty, look at those things, and then actually use those as measures of what is happening, not just sort of Black, white, Asian, Native American, Latino.
I think that's a great point, Rukaya. Not only is it on, and I'll bring Jim on this conversation as well, because this is so important for public health. I'm reminded of a study published many years ago in one of the fields. I do a lot of transport and injury research, and there was a study out of the Middle East defining the injury rates by nationalities. And it almost made to seem as if it's those Pakistanis, it's those Nepalis, it's those Indians, it's those Sri Lankans, as opposed to saying, wait a minute, it's not being a nationality that causes you to have that injury, it's something else. So I think you're pointing that out of the double-edged sword, so to speak. So Jim, some reflections on this point, which is so important for public health.
Yeah.
And if you could add your closing reflections on top of that, that would be great.
Sure. Well, maybe I'll just make them because I know we're running out of time. So just a couple of points I want to add on those great comments from Professor Yarby. The first one is a study that I used to use in my teaching about equity. And it was like a large scale public health intervention about whatever, I can't remember what it was, something about cardiac outcomes. And the study made everyone better off. Everyone was better off, but it increased disparities. And so the question is that because we love to talk about equity. We just love it. Everyone loves it. It's people's favorite word. So if we renew the way that we gather evidence through a lens of equity, that's a failed study, even if everyone is better off. Or not a failed study, but it's an incomplete success. Maybe that's a fairer way to put it. So I think we have to grapple with the underlying accounting that we have to do back to those ethical structural pieces like equity. The second thing I think that we're going to see invariably in the vaccine pipeline for COVID is narrow constructions of what constitutes effectiveness. And if we have a log jam of vaccines, a very likely scenario is that we're going to have a log jam of partially efficacious vaccines that hover somewhere in the 55 to 60% efficacy rate. So their efficacy differences may actually be quite small. And if, let's say we have an RNA vaccine that you can manufacture rapidly, that's cheaper. If you have a 1% lower efficacy of an RNA vaccine that's 10 times cheaper to manufacture, people will argue that it's a worse vaccine. But if I'm purchasing it on behalf of a country where I'm trying to get more coverage, the value of that vaccine for me could be much, much higher. So we don't do a good job at rolling these kind of broader accounts of value and ethics into the way we structure the evidence that gets privileged in our evidence-based society.
Great. No, thank you very much. I really appreciate that, Jim. And Rukaya, over to you for a minute of closing reflection.
So I would just say that hopefully today you've begun to think about these disparities differently and the work that we need to do to address structural issues. It's not going to happen overnight, but part of it is empowering people to be able to do the best for themselves. I think what we often forget is that people in vulnerable communities know what they need. It's not that they don't know what they need, it's that they can't get what they need because of the lack of access to equal opportunity and resources. And so if anything good can come from COVID-19, I hope that is we begin to shift power, resources, support, and value these communities because they are so important.
Well, you know, thank you very much to both of you. I think that you've provided us a lot of reflection on from questioning the identification and documentation of race itself to the way we measure things and the implications, first of all, of not measuring versus the implications of measuring, but not delving deeply and thoughtfully into what we are measuring. I think is incredibly important. Today, ladies and gentlemen, we have talked about avoiding the notion of blaming the victim, blaming the minority. And in my field of injury prevention, that is fundamental, right? We don't want to blame the victim. We want to change the system so that no matter how you drive, you don't die. And this is what we are talking about today. No matter what your life choices are, you should not be treated on the basis of what your, to use Jim's expression, phenotype represents. I think we've talked about the power of agency, which is so important, and identifying that ethics, for folks like us, ethics affords a language, a lens, an ability to think through many of these issues, because we want to talk about justice and fairness, which is one of the cardinal principles of bioethics in particular. We want to talk about who's being harmed and who's benefiting. And that gets us into, from ethics, into the conversation around power. And fundamentally, these are huge questions, but they are also questions for all of us in every single country of this world. I am not familiar of any country where there are no inequities, where there is absolute justice existing. So whether you are from Africa or you're from South Asia or you're from right here in the United States, I hope this conversation has been useful to you. I am delighted and honored that Professors Yarby and Lavery joined us. It was just an honor for us at GW to host both of them. Thank you to all of you who participated. I want to apologize again to a couple of you who needed some extra assistance. I really hope if you and your colleagues could alert us in advance of who will be joining, and we'd be very happy to provide both audio and video assistance to those who find it a little challenging. Please join us in 2 weeks on the 21st of July for our next webinar in this series. I look forward to welcoming many of you. Thank you for your patience and audience, and thank you again, Professors Yarby and Lavery. Take care, and wishing everyone safety and health. Bye-bye.